And I'm going to be presenting on chemotherapy-induced nausea and vomiting, or CINV. I do want to mention that I'm not going to be talking about any radiation-induced nausea and vomiting today, just to keep it to a more narrow scope. Is everybody able to see my slides okay?
Yes, I can see them.
Okay, great. All right, so just a little bit of background on myself. I am a clinical pharmacist practitioner at the Johns Hopkins Hospital in Baltimore, Maryland, and my practice area is adult blood and marrow transplantation. Could you guys on the call maybe tell me your names and what centers you currently practice at?
Sure. My name's Sherry Biendo, and I work for Nanticoke Memorial Hospital in the Cancer Center. It's in Delaware.
Okay,
And
great.
thank you. Previously, I worked at Yale New Haven Hospital in Connecticut. I just came down here. I've been here for 6 months.
Okay, great.
Thanks.
Who else do we have on the call? There's Samantha.
Yeah. Hello?
Hello.
Samantha, can you hear us? Okay, we'll just wait for her to reconnect, and then she can join us later. I'll send her a little message.
Okay, should I keep going then?
Yeah.
Okay. All right. So we're going to start by talking about just some background on CINV. And one of the reasons that we're talking about CINV today is because it's been a very high side effect that patients experience undergoing chemotherapy. Previously, it was reported that up to 70 to 80% of our patients with cancer would experience MSS. But thankfully, over recent years, we've had a lot of effective antiemetics that have come to market. So currently, we're seeing rates of more of about 35% of CINV in patients receiving highly emetogenic chemotherapy and about 15% with moderate. So definitely much better than it was before. But it still obviously affects a good amount of patients and still remains one of the most feared side effects of chemotherapy. It does have a lot of negative consequences, such as impairing a patient's functional activity, certainly decreased quality of life. We can also see that if a patient has really severe nausea and vomiting, that they may not be interested in continuing on their treatment, which may be the most effective option for their disease. And obviously it can lead to increased healthcare resources as well. Now, another thing I just want to mention before we move forward is the difference between nausea and vomiting. So this is, I think a pretty obvious thing where nausea is really the feeling of having an inclination to vomit, whereas vomiting is the actual act of doing so. But I think the important thing to recognize is that nausea is a subjective feeling. So while you may have patients that don't have any episodes of vomiting at all, they may have really severe nausea, which can have a very negative impact on patients' quality of life. It can be more difficult for us as providers to be able to assess and to quantify. And it can also have more of a variable response to drug therapy. So just important to keep in mind as you're assessing patients that not all of our patients will experience vomiting, but nausea can be an equally, if not more so, troubling side effect. Okay, so there are some risk factors that can increase a patient's risk to developing CINV. So certainly based on the patient's disease or regimen factors. So depending on the patient's location of their disease or symptoms of their tumor, that can contribute to CINV, as well as the chemotherapy regimen itself, such as the specific agent, dose, schedule, or route. We'll talk a little bit more about that when we get to levels of emetogenicity. There's also a number of individual risk factors as well. So it's more common in our younger patients than our older patients, as well as our females. It's more common than males. Patients who are alcohol naive can actually have a higher risk of nausea and vomiting than patients who have a high alcohol tolerance. are patients who have had morning sickness with pregnancy or patients with motion sickness. And I think this is really just, those patients have somewhat of a predisposition for having more problems with nausea and vomiting in general, and so can be more likely to develop CINV with their chemo. And then certainly our patients who have had prior chemotherapy and specifically a history of CINV can be more likely to experience that with their future regimens. Okay, so pathophysiology, there is a lot that we do know, but a lot that we still don't know about how CINV occurs. But basically, CINV is result from stimulation of a multi-step pathway that's controlled by the brain. And so we know that nausea and vomiting are controlled by the vomiting center, and afferent stimuli will arrive from central and peripheral sources. This may include the chemoreceptor trigger zone, which senses stimuli in the blood and CSF, also the GI tract or pharynx, the vestibular system, as well as the cerebral cortex, which is responsible for more of our learned kind of responses. So some of these areas like the CTZ, the vomiting center, and the GI tract have many neurotransmitter receptors, and so activation of these receptors by chemotherapy agents is what can trigger chemotherapy-induced emesis. So it is important to keep in mind that we have some common neurotransmitters that are responsible for CINV, but there are some others that may have an involvement, and we just don't know fully exactly how they interact with these receptors. Can you guys tell me what the most common neurotransmitters are that we target as far as our antiemetics?
Serotonin.
Yeah.
Yep, good. Serotonin's a big one.
Yeah, also dopamine probably.
Mm-hmm. Good. So serotonin, dopamine, and what's the other big one?
What's the 5-HT? Is that serotonin?
That's serotonin, yep.
Okay.
Yep. So we have substance P, which is a neurotransmitter that acts on the neurokinin receptor. So serotonin, dopamine, and substance P are our big neurotransmitters that we target with our current drug therapies that we have available. As I mentioned, there may be some other neurotransmitters that are also involved, but we don't routinely target with our prophylactic regimens. Those can include acetylcholine, corticosteroid, histamine, cannabinoid, and opiate. So it's important to keep in mind that we have these various neurotransmitters and that at certain concentrations, when we have antiemetic agents that target, they predominantly target one receptor type. So we don't have one common pathway that's been identified for nausea and vomiting that one single antiemetic agent can be expected to provide complete protection through the various phases of nausea, vomiting after chemotherapy. So that's why it's important that when we're designing our prophylactic regimens, that we're targeting our regimens towards the most common neurotransmitters, and we're going to be using several agents to accomplish that. Okay, so it's also important to think about differential diagnosis. Now, many of the times what you will see in your practice when patients have nausea and vomiting is that it will be as a result of chemotherapy, but certainly we do need to think about potential other causes as well, because obviously if we focus our efforts on just assuming that it's from chemotherapy, we could miss something else that really is the underlying cause. So some of these patients could have metabolic complications that are leading to their nausea and vomiting. Certainly there's other medications such as opioids are a big one in our patients with cancer that can also contribute to nausea and vomiting. We can also see physical causes. So if, for example, the patient has a GI obstruction, that could be causing the nausea and vomiting, not the chemotherapy itself that the patients are receiving. Or if a patient has CNS involvement of their tumor, that can also contribute to symptoms of nausea and vomiting as well. Certainly we can also see some nausea and vomiting that is triggered by anxiety or emotional causes. also. Okay, so levels of immunogenicity. We're going to go over how the NCCN classifies immunogenicity. I will say that previously the system that was used for calculating the risk was significantly more complicated, where you looked at the individual agents and you assigned almost like point values to each agent and how to put it all together, and it was relatively cumbersome to use. The new system that we have now is much easier to interpret, and also, which in turn makes it easier to design your antiemetic regimen. So this table is from the NCCN guidelines. Basically, emetogenic risk is put into 4 different categories. We have either high risk, moderate risk, low risk, or minimal risk. And so basically what this means is each risk level is based on the percentage of patients that would experience acute emesis if they were not receiving any type of antiemetic prophylaxis. So you can see that a patient in the high-risk category is going to have a greater than 90% chance of chemotherapy-induced nausea and vomiting if they did not receive any of the appropriate antiemetics. Conversely, patients in the moderate risk category have a pretty wide range. Anywhere from 30 to 90% of patients would experience emesis in the absence of effective antiemetic prophylaxis. Then we have our low category, which is 10 to 30%, and our minimal category, which is less than 10%. There are some very obvious limitations, I would say, to this classification. Obviously, it is very easy to use. It's easy to define what your individual agents are, and also how to assign a risk category for your regimen. Is everybody familiar with how to assign the risk category when you're looking at a chemotherapy regimen rather than a single agent? Okay, so basically what you will do is if you have a combination chemotherapy regimen, you will look at each of your individual agents and determine what risk category each of them fall into. And then whichever one has the highest level of emetogenicity, that's how you're going to classify the entire regimen. So for example, if you have a chemotherapy regimen that combines cisplatin, which is a high emetogenic risk, with perhaps agents that fall into the low or minimal risk categories, that regimen would still be classified as a high-risk regimen because cisplatin is the highest emetogenic risk in that, that regimen, so you want to make sure you're covering the patient for that highest level of risk. Does that make sense?
Yes.
Okay, great. Can you guys name some of the other chemotherapy drugs that fall into our emetic risk categories? So I mentioned cisplatin. I think that's a hallmark drug that is a highly emetogenic risk agent. And I will say too, before I have you guys chime in with some of the examples, you do kind of have to watch with some of these guidelines because up until like about 1.5 years ago, cisplatin could either be classified as moderate or high risk depending on what dose you are using. And then more recently, it was updated to only be classified as a high-risk agent regardless of dose. So you will want to make sure that you kind of reference the guidelines frequently because there sometimes can be changes that will affect how you might put together your antiemetic regimen. So what other things would fall into the high emetogenic risk class, common agents?
Doxorubicin.
Yep, the doxorubicin, generally doses greater than 60 mg per meter squared.
Cyclophosphamide.
Good, so cyclophosphamide at higher doses as well. I would say that also the only combination regimen that you're going to see in the guidelines that falls in the emetogenic tables is AC for breast cancer. So AC will always be classified as a high emetogenic risk. Other than that, a combination example, every other risk category, you're just going to see individual drugs. Okay, good. What about some of our moderate emetogenic risk agents?
Carboplatin.
Yep, good. Carboplatin.
Irinotecan.
Irinotecan, good. We can see some of our lower doses of doxorubicin and cyclophosphamide falling under the moderate risk category. some of our other anthracyclines, oxaliplatin. So those are all common ones that we're going to see as moderate risk. What about some low emetogenic risk agents?
Etoposide.
Okay, good.
5-FU.
Okay. Yep, good. Those are some common ones. Pemetrexed, for example, brentuximab. Some of our liposomal anthracyclines will fall under the low emetogenic risk. And then minimal emetogenic risk, we have some of our monoclonal antibodies, specifically bortezomib. So basically, it's a good idea, like I said, to utilize a table frequently, especially if you're building order sets or making decisions on designing a regimen for an individual patient. Now, as I mentioned, there are some limitations to how we classify antiemetics. Using this classification, we have our levels of emetogenicity, so the frequency that we would expect nausea and vomiting to occur. But this does not differentiate between which agents are most likely to cause acute or delayed nausea and vomiting. And again, we do have a mechanism for assigning risk to our combination regimens, but the recommendations themselves do not include any combination regimen specifically besides AC for breast cancer. So those are some things to keep in mind, that as you're using these tables, there are some limitations. Any questions on any of that?
No, thank you.
All right. So moving on to types of CINV, we do classify nausea and vomiting based on when it occurs following chemotherapy. So we have acute nausea and vomiting, and this generally occurs within the first 24 hours after chemotherapy administration. Usually the peak is seen at about 4 to 6 hours after chemo, and acute nausea and vomiting is generally thought to be pretty responsive to drug therapy. This is where our 5-HT3 antagonists or serotonin antagonists are most effective. So that's where you'll generally see serotonin antagonists utilized in your drug regimen, is around the acute phase of CINV. For delayed nausea and vomiting, this occurs at least 24 hours after chemotherapy administration, but can happen up to 7 days after chemo, and the peak effect is usually seen around 2 to 3 days after chemotherapy. Now, what we generally see here is that delayed nausea and vomiting usually involves the neurotransmitters other than serotonin. So our substance P or dopamine. So you'll see drugs that affect these pathways utilized more in the delayed nausea and vomiting setting. And some of the agents, the chemotherapy agents that we're most likely to see delayed nausea and vomiting with are cisplatin, carboplatin, cyclophosphamide, and some of our anthracyclines. Now, anticipatory nausea and vomiting occurs as a result of a conditioned response from previous chemotherapy treatment. This commonly occurs in patients that have had a prior negative experience with chemotherapy, and so it really becomes a conditioned response. This can sometimes be challenging to treat in patients. I've had some patients in my practice who have had really severe anticipatory nausea and vomiting. And I think all of us have probably heard the stories of patients who see their oncologist or somebody from their treatment team at an outside location and associate that person with their chemotherapy and have problems with nausea and vomiting when they see them. So it can be a pretty strong effect that we can see. And one of the reasons why it's so important to try to manage CINV earlier on and try to prevent it as best as possible. Because when patients do have really poorly controlled nausea and vomiting, we know that this can lead to problems with anticipatory nausea and vomiting in the future. And then we also have breakthrough and refractory. Can you guys tell me what the difference is between breakthrough and refractory nausea and vomiting?
Breakthrough would be if you had nausea, you took something, and then before it was time for the next dose, you would have nausea. And refractory probably would be like nothing's working and they're just nauseous.
Good. Exactly. So breakthrough is really your vomiting, nausea or vomiting that occurs despite receiving what would be considered appropriate prophylactic treatment and requires rescue. So I think it's not dissimilar to pain management, where we might have patients on a long-acting opioid, but despite being on that, they sometimes have periods of pain and require short-acting opioids. Similar kind of concept with nausea and vomiting, where you can have a patient on an appropriate antiemetic regimen, but the patient may still experience waves of nausea and vomiting throughout and should have an agent available for breakthrough dosing. Refractory nausea and vomiting usually occurs during subsequent treatment cycles when antiemetic prophylaxis and rescue have failed. And so these can really be challenging patients, in my experience, where they've gotten all of the usual antiemetics appropriate for the level of emetogenicity. The regimen has been appropriately tailored and adjusted to try to help provide them relief, and despite all that, the patient still continues to experience nausea and vomiting. So this is where it's really important as pharmacists to understand what neurotransmitters are involved in CINV so that you can appropriately make sure that you're targeting the correct neurotransmitters with the drugs that you're using, and helping to make sure that the patient has adequate coverage. Okay, so now we'll move on to our antiemetics. So antiemetics will block the neuronal pathways at different points during the course of emesis. Now, it's important to try to prevent nausea and vomiting as much as possible. So with an ideal regimen, we would want to initiate our regimen prior to chemotherapy and then continue it for the duration that the patient is at risk for nausea and vomiting. It's also important to remember that we have a lot of different routes of administration that are available to us depending on the drug. So we have PO, we have rectal, IV, intramuscular, transdermal. So there's a lot of different options potentially that can be utilized in a patient who has difficulty responding to our traditional routes of administration. Okay, so first we'll start with the serotonin receptor antagonists. These are drugs that block serotonin receptors in the gut and the chemoreceptor trigger zone. So they mostly have a peripheral mechanism of action. The drugs that we have available are ondansetron, granisetron, and dilasetron, which are our first generation 5-HT3 antagonists, and then palonosetron, which is our second generation 5-HT3 antagonist. It is important to note that these drugs all have a good oral bioavailability, with the exception of palonosetron, which we predominantly use IV, and that our first generation 5-HT3 antagonists are considered equally efficacious, so ondansetron, granisetron, and dilasetron. We'll talk a little bit more about the dosing options that we have available for each of those agents. Some of the most common side effects of 5-HT3 antagonists that patients complain of, I would say predominantly, are headache and constipation. Certainly as healthcare providers, we do need to be aware of QTC prolongation. I know in my patient population, which is bone marrow transplant, we give a large number of drugs that prolong QTC. So it is important to keep that in mind and initiate the appropriate EKG monitoring if you have a patient that's receiving multiple QTC prolonging drugs. Okay, so ondansetron, I think is a very common 5-HT3 antagonist. I know at our institution it is our preferred formulary option. It is available in IV, oral, and also an oral disintegrating tablet. So the ODT can be very helpful in your patients that are unable to have difficulty swallowing oral medications but are still able to take things enterally. You do have to watch with ondansetron as well as all of your 5-HT3 antagonists as far as the max dose that's given, because in general higher doses of these drugs leads to more of an effect on QTC. So the max single dose of ondansetron is 16 milligrams. Granisetron we have available IV PO as well as a transdermal patch. The transdermal patch, I think, is a helpful dosage form, particularly for patients where they're outpatient and are unable to take PO and it's not practical for them to come to the clinic routinely in order to be able to get IV dosing. And then we have Dilasitron, which we only have available as a PO option. It did come in an IV formulation, but the IV is not recommended because of the higher risk of QTC prolongation seen with it. So I think a lot of centers probably do not use Dilasitron as frequently as ondansetron and granisetron, just simply because we only have one dosage form that we can really utilize in our patients. Palonositron, as I mentioned, is a second-generation 5-HT3 antagonist, which is definitely a little bit more unique than our other agents in that it has a 100-fold higher binding affinity for the receptor, and also has a significantly longer half-life. Now, I will say that when the studies first came out for palonositron, there was some criticism of those studies because palonositron as a single dose was being compared to a single dose of ondansetron, which we know is not exactly a fair comparison given the difference in half-life, and we would obviously expect palonositron to last for significantly longer than we would expect with ondansetron. But palonositron definitely is a good agent to use, particularly if you have a patient that has some compliance issues, because we currently have it only available in an IV formulation. I'll get to the PO in a moment, but our typical dosing is IV. It's given one time before chemotherapy, and it lasts for several days. So from that end, it's a very nice option. And all of these are included as options in the NCCN guidelines for our various levels of immunogenicity. But as I mentioned, there really is no difference in efficacy between our first generation 5-HT3 antagonists, and it is recommended that these drugs be combined with a corticosteroid for maximum efficacy. And then again, these drugs do have a really good oral bioavailability. So if you have a patient that's able to successfully tolerate oral drugs, you can feel comfortable giving the drugs that are available orally and not having to give IV, because we know that oral does have good bioavailability. Now, obviously, if you have a patient who's actively vomiting and isn't able to keep their medications down, then you would want to go with IV or another route of therapy, just because you wouldn't want to give a medication that a patient would vomit up. Do you guys have any questions on the various 5-HT3 antagonists that we have available? No? Okay. We'll move on to our neurokinin-1 receptor antagonists. So these drugs work by blocking the binding of substance P at the NK1 receptor, and they have a predominantly central mechanism of action. Now, it's important to note that the NK1 receptor antagonists provide a complementary mechanism of action to all other available antiemetics. So they were studied in combination with a 5-HT3 antagonist and a corticosteroid. And so that's how it's recommended that they be used. I know that there are sometimes providers who are interested in using the NK1 receptor antagonists as single agents or for refractory nausea and vomiting. We currently don't have a lot of data in that setting. The data that we have is really in combination with a 5-HT3 antagonist and a corticosteroid to prevent nausea and vomiting with moderately or highly emetogenic chemotherapy regimens. Now, as I mentioned previously, that our delayed phase of nausea and vomiting is most affected by dopamine and substance P, and so the neurokinin-1 receptor antagonists are particularly effective for delayed nausea and vomiting. So we've had our drug options for the NK1 receptor antagonists expand a little bit in recent years. Aprepitant is the first drug that we had available, and aprepitant is only available orally with a loading dose of 125 milligrams on day 1 and 80 milligrams on days 2 and 3. Fosaprepitant was the next formulation that came out, so basically an IV version of aprepitant. The dosing used to be different when it first came to market than it is now. We now use a dose of 150 milligrams IV times 1 dose on day 1. Rolapitant is the newest of these agents. It was just FDA approved within the past couple years. That is another PO option, although I would say, the big difference is that for Rolapitant, you give 1 dose on day 1, and it does not need to be repeated on days 2 and 3 like aprepitant does. But the last I looked, the estimated cost of Rolapitant was about $600 per dose. And certainly, I know that a lot of centers don't have as much clinical experience with the drug, so I think it's something that we'll probably see more of when centers gain more experience with it. Now, as far as side effects, I think I actually skipped that on the last slide, so we'll just go back. So side effects, these drugs are very well tolerated. I've actually never had any patients complain of some of the side effects that are listed, fatigue, hiccups, or diarrhea. What I have seen is patients potentially complain of some burning with the fosaprepitant infusion, which can normally be decreased by either further diluting the fosaprepitant or increasing the time of infusion. But otherwise, pretty well tolerated. I would say the really important thing for us as pharmacists to keep in mind are drug interactions, particularly with aprepitant. So aprepitant is a major substrate of CYP3A4 and also a moderate inhibitor of CYP3A4. It's also a strong inducer of 2C9. There are some other CYP interactions as well. So you really have to be careful, particularly patients that are on warfarin, for example. It can affect INR. There are some interactions with chemotherapy agents, which I think was a big concern when aprepitant first became available. I think now, with having more experience with aprepitant, most oncologists do not empirically decrease the dose of chemotherapy when aprepitant is used in conjunction, but certainly it's something to be aware of, that patients could have potentially increased side effects as a result of drug interactions. Fosaprepitant also is a major substrate of CYP3A4 and a weak inhibitor. It's also a weak to moderate inducer of 2C9. And Rolapitant has some CYP3A4 2D6 interactions as well. So I would just urge you to be cautious when you're looking at drug interactions. And that is also one of the reasons why you will see, when we get to putting our antiemetic regimens together, why the steroids are decreased when used in combination with an NK1 receptor antagonist in an antiemetic regimen. It's because of the drug interactions seen with our NK1 receptor antagonists. We do also have another interesting drug combination that was approved a little over 2 years ago. This combines, interestingly, 2 drugs that we don't have available individually. Palonosetron we obviously have available individually as an IV formulation, but this is the first oral formulation of palonosetron that we've seen commercially available. This combination is nitupetant in combination with palonosetron. And so nitupetant is our NK1 receptor antagonist, and we know that NK1 receptor antagonists augment the antiemetic activity of 5-HT3 antagonists and steroids. And then we have palonosetron, which blocks serotonin and inhibits crosstalk between 5-HT3 and NK1 receptors. So basically, this combination works synergistically to inhibit substance P response to a greater extent than we would see if either agent was used alone. It does come in an oral dosage form combination capsule of 300 milligrams of nitupetant and 0.5 milligrams of palonosetron. Cost is about comparable to what I mentioned with Rolapitant. It's about $600 a capsule. And the patient would take 1 capsule 1 hour prior to the start of chemotherapy. So obviously this could be a nice option for patients, particularly that have compliance issues, where they would only have to take 1 capsule that would get them their full 5-HT3 antagonist and NK1 receptor antagonist coverage for their regimen. Do either of you guys have experience with using the new combination of nitupidine and palonosetron?
No, I don't.
I don't
No, us
either.
either. It's not improved on the inpatient side, so.
Yeah, same here. We don't use it inpatient. I think at some point we might start to see it more in the outpatient, but surprisingly, it really hasn't caught on quite as quickly as I thought it might, given the convenience factor for patients. Okay, so moving on to corticosteroids. We know that corticosteroids are a very active part of our antiemetic regimens. We just don't really know why. The mechanism of action in CINV is not clear. But what we do know is that their use is most beneficial when they're used in combination with other agents, so our 5-HT3 antagonists and our NK1 receptor antagonists. So there are a couple of things that I just want to mention. So we talked about with the NK1 receptor antagonists that you will see recommendations to reduce the dexamethasone dose when dexamethasone is used as part of the antiemetic regimen. Now, what I just wanted to point out is that when a steroid is given as part of the chemotherapy regimen itself, so not as a part of the antiemetic regimen, but part of the actual therapeutic effect of the chemotherapy regimen, we would not decrease the dose of the steroid because we want to make sure that the patient is getting the full benefit of their chemotherapy regimen. So some examples that I can think of are for like our lymphoma regimens. Like our CHOP, for example, we would never reduce the dose of the prednisone if we were adding an NK1 antagonist, or some of our acute lymphocytic leukemia regimens, for example. So our regimens where steroids are being used as part of the therapeutic benefit, we would not want to decrease. It is important to remember that steroids have a whole slew of toxicities associated with them. So potentially you might sometimes see steroids omitted for various reasons, like if you have a patient who has very poorly controlled diabetes, where every time they get a steroid as part of their antiemetic regimen, they end up in DKA, for example. There might be those types of situations where we need to eliminate the steroid as part of an antiemetic regimen, but we also have some potential disease state contraindications as well. Some of this can be institution specific. But like here at Hopkins, for example, working with the bone marrow transplant group, we use a lot of post-transplant cyclophosphamide for graft versus host disease prophylaxis. And we know that using steroids can blunt the effect of the cyclophosphamide on lymphocytes. And so we do not use steroids in our regimens, even though it would normally be recommended as part of the NCCN guidelines based on the level of immunogenicity. So sometimes you do have to just be aware that there may be certain disease states or some of our immunologic therapies we may not want to give steroids. So you just need to keep that in mind, that there may be times where we stray from the guidelines for very specific disease states where we don't want a steroid used. Okay, olanzapine. Have either of you used olanzapine for nausea and vomiting?
No, I haven't.
No? Okay. Olanzapine, as we know, is an atypical antipsychotic, but it's an interesting drug for CINV because it can target multiple different receptors. And originally when we were seeing olanzapine used in CINV, it was being used more in the refractory setting. So again, our patients where despite receiving appropriate prophylaxis and breakthrough treatment, these patients were still experiencing nausea and vomiting. And it had really a good effect there, and that's where I've used it the majority of times in my patients with refractory nausea and vomiting, and still do use it in that setting. But what we're seeing now as well is that it's been being increasingly used for prophylaxis as part of our regimens. So there's a couple papers, and the full reference is on the last slide. But the paper in 2011, where basically the NK1 receptor antagonist was removed from the prophylactic regimen and replaced with olanzapine, and basically found that there was equal efficacy when replacing NK1 antagonists with olanzapine. And then there was actually just a study published several months ago in the New England Journal of Medicine that looked at adding olanzapine to our traditional highly emetogenic antiemetic regimen. So the combination of our steroid, our 5-HT3 antagonist, and NK1 antagonist. And they found that the addition of olanzapine improved efficacy. So I think this is a really good drug to keep in your back pocket. Now, I would say here at Hopkins, we have not seen, again, despite some of these papers being published, we still tend to use more of our NK1 receptor antagonist-based regimens for moderately and highly emetogenic chemotherapy. I haven't seen too many requests from providers to replace out the NK1 receptor antagonist with olanzapine, but it's certainly an interesting idea, especially since olanzapine is significantly cheaper than our NK1 receptor antagonist that we have commercially available. So I think that we're going to see a lot more of olanzapine being used in the future in prophylactic regimens and being studied in various combinations. But what I can tell you is I do have a lot of experience using it in patients with refractory CINV and have had very good success with that in that setting. So I think it's a nice drug to be aware of so that you can potentially use that in your arsenal of drugs that you have available. Some of our other agents that we have available are dopamine antagonists, Prochlor, Pyrazine, and promethazine. I would say these are drugs that are commonly used as first-line breakthrough agents. So when you have a patient who needs some anti-emesis rescue, those are two very good drugs. Now with our phenothiazines, we do have to worry about sedation, QTC prolongation, but they are available in a number of different dosage forms, which can be really helpful for our patients who are unable to take a medication orally. We also have metoclopramide, haloperidol, droperidol. Again, we need to worry about QTC prolongation, and generally with any drug where you're blocking dopamine, you do have to be worried about the potential of extrapyramidal side effects. So I generally do try to be cautious if you're combining multiple dopamine blocking agents. The risk of extrapyramidal side effects could increase. So you just want to be cautious of the drugs that you're using and at what doses. But very effective drugs, haloperidol in particular, can be very effective for your patients who have some delirium where you're hesitant to use some of the other agents that can cause a lot of sedation. That can be a really nice drug for that purpose. We also have our cannabinoids, so dronabinol and nabilone. I've only ever used dronabinol, but these can be good drugs, particularly for patients who have some nausea and vomiting and also need some appetite stimulation. You do have to watch that their central nervous system side effects can be more pronounced in elderly patients. So I've had some mixed successes with these drugs. There's some patients that they work really well in and others they don't. But you just kind of want to be aware of the potential for increased drowsiness. Some patients will complain that they feel a little bit loopy in some of our elderly patients. And you also do want to watch for orthostatic hypotension, so educating your patients to be careful when standing up from like bed or from sitting, just to be careful that they don't fall and they take their time. We also have our benzodiazepines, lorazepam and our alprazolam, I think are the ones that are most commonly used. And these are obviously not true antiemetics, but they can be very helpful in our patients who have anticipatory nausea and vomiting, since that's more of a learned kind of response and cognitive kind of response to nausea and vomiting. And so lorazepam and alprazolam can be really helpful drugs in those patients who have a really strong anticipatory component. I also have used it in some of our patients with more like refractory kind of nausea and vomiting if I suspect that some of what they're experiencing is due to their experiences with prior cycles of chemotherapy. And then last but not least, we have our antihistamines, meclizine, scopolamine. Now you do have to watch with these drugs because they are anticholinergic, so especially in our hospitalized patients, we can see some delirium, sedation, orthostatic hypotension, but they can be very good drugs for patients who have a lot of secretions associated with their nausea and vomiting to help dry things up, but you do want to watch those anticholinergic side effects, especially in our elderly patients. The scopolamine obviously is a nice option in the aspect that it's a transdermal patch. But as a word of caution, you do have to be careful because if you have a patient who has a scopolamine patch applied for quite a long time, you actually do need to taper it off. Otherwise, they can have withdrawal symptoms, which I've seen patients experience before. And since you can't taper a patch, you would then normally use meclizine to taper. So just something to keep in mind, you wouldn't want to stop a scopolamine patch in somebody cold turkey if they've been on it for a while. Okay, so now to put everything together, I just kind of wanted to go through the NCCN guidelines. So we've talked about the individual drugs, and we've talked about how to determine the level of immunogenicity. And so basically the way the NCCN guidelines breaks this down is they have tables based on high emetogenic risk, moderate, or low or minimal. And so they have a couple different options of regimens, antiemetic regimens, so options A, B, or C. And what it'll show in the first column is day 1 of chemotherapy. And then in the second column, in this case, it's for days 2, 3, and 4. So there's a lot of different combinations of antiemetics that can be used. I think the most important thing to remember for the highly emetogenic chemotherapy is that patients will receive a combination of an NK1 receptor antagonist, a 5-HT3 antagonist, as well as a steroid. And so unless you decide you want to use olanzapine in place of your NK1 receptor antagonist based on the paper that I mentioned earlier. So basically, in the first column, you'll see options for your NK1 receptor antagonist, so aprepitant, fosaprepitant, or rolapitant, and the appropriate dose that you would give on day 1. You'll also see the 5-HT3 antagonist, so the lansitron dose, granisetron dose, or ondansetron or palonosetron, and then your steroid dose. And then you'll see exactly how you need to dose on days 2, 3, and 4. So you'll see that if you did choose to give your NK1 receptor antagonist on day 1, you're going to see a lower dose of steroids again used on day 2, 3, and 4 to account for that drug interaction that is seen with NK1 receptor antagonists. So, so I think there's a lot of different options there, but I think the easy thing to remember about highly emetogenic antiemetic regimens and building them is that the patient's going to get everything. So you are going to include all 3 of those drugs that target some of our major receptors. So our NK1 antagonists, our 5-HT3 antagonists, and then our steroid, because we know that that helps to augment the efficacy. And then you would want to make sure that the patient has an appropriate breakthrough antiemetic available to them as well, like prochlorperazine or promethazine. Excuse me. So next we have our moderately emetogenic risk regimens. I think this tends to be a little bit more where people get confused. And the reason for this is because, as I mentioned before, that a moderately emetogenic chemotherapy regimen can have the risk of emesis of anywhere to 30 to 90%, which is a pretty broad range. And so sometimes it can be difficult for providers to know when or when they should not consider using an NK1 receptor antagonist. So what I would say is for the moderately emetogenic chemotherapy regimens, it's very similar in concept to what we saw with our highly emetogenic regimens. If a patient is to receive the NK1 receptor antagonist with the 5-HT3 antagonist and the steroid, you're going to see that they get those drugs on day 1, and then whatever follows on days 2 and 3 will usually be your steroid and potentially more of your NK1 antagonist, depending on which one you chose initially. Now, if you have a moderately emetogenic regimen where you think maybe an NK1 receptor antagonist is not necessary, then you'll have your regimen of your 5-HT3 antagonist and just a steroid on day 1. And then on the subsequent days, you'll give either a serotonin antagonist or steroid. So I think this tends to be a little more confusing for providers just because there's more options. And sometimes it can be difficult too, especially if you're not as familiar with a combination chemotherapy regimen and it falls into that moderately emetogenic risk category. whether the risk is closer to that 90% range, in which case you probably want to add the NK1 receptor antagonist and treat it more similarly to the high-risk regimen, versus if we think it kind of falls more towards 30% of the end of the range, where just using your serotonin antagonist and your dexamethasone may be sufficient. Do you guys have any questions on that?
No, I'm all set, thanks.
Yep. Okay, so I would definitely urge you to utilize the guidelines and look at all the various options, because it can definitely be a lot to remember between all of the different drug options that we have available now and the various doses depending on what combinations they're being used in. And when you get to our low or minimal risk, this is actually where it's pretty easy. So for our low level of immunogenicity, you basically just need to give the patient something scheduled. That could be dexamethasone, it could be a dopamine antagonist like Reglan or prochlorperazine or promethazine, or it could be one of our serotonin antagonists like granisetron or ondansetron. Palonosetron is used mostly for moderately or highly emetogenic, which is why you don't see it listed here in our low emetogenic category. But basically, you just need to make sure that the patient gets one scheduled dose of something. Whereas with our minimal risk, there is no routine prophylaxis that's needed. But again, I would definitely suggest making sure that the patient has something available for breakthrough, even if they're a patient that falls into a category where they're getting a drug that's a minimal emetogenic risk, just because depending on the patient's history and their disease state, they could potentially still have some nausea, and it would be appropriate for them to have antiemetics available to them at home, especially if they're experiencing any nausea and vomiting at night or on the weekend when it can be harder to get in contact with their provider. Okay, so some general treatment principles. You want to make sure you base your antiemetic regimen on your chemotherapy agent with the highest emetogenic risk. And you also want to make sure that your regimen that you select covers the entire period that the patient is at risk. You do want to make sure that you're using drugs prophylactically. And you also want to make sure that you're including individual risk factors. So again, like if you have a patient where they're getting a chemotherapy regimen that's moderately emetogenic risk, and you're trying to make the determination about adding in an NK1 receptor antagonist, part of that decision making should also include the individual patient's risk factors. What have they had for chemotherapy before? Are they at higher risk for nausea and vomiting? And that can also help you make that determine and how you want to tailor the regimen to the individual patient. You also want to make sure that this is not a once and done kind of deal where you select the antiemetic regimen at the beginning and you just kind of move forward on autopilot. So you really want to make sure that you're assessing the effectiveness of the regimen from previous chemo cycles and then adjusting as needed. Again, because it is really important to try to get the best control of nausea and vomiting as possible, so that you can try to prevent issues with further nausea and vomiting down the road, and particularly anticipatory nausea and vomiting, which can be difficult to treat. For breakthrough or refractory nausea and vomiting, you do want to make sure that you choose agents from a different class other than the prophylactic regimen. So it's not uncommon to see where providers may put a patient on the 5-HT3 antagonist as part of their antiemetic regimen, and then for breakthrough they give them more 5-HT3 antagonists. Generally what you want to do is make sure that your breakthrough agent targets a different neurotransmitter so that you can make sure that the patient has adequate coverage. We also know that there is not one single agent that's more effective than another for breakthrough or refractory, so sometimes it can take some trial and error to try different things, different drugs, try different doses and different frequencies before switching to another one to really try to optimize the patient's regimen. And you'll sometimes see that patients may require more than one breakthrough agent, as well as sometimes patients that will require agents that we would normally think of as breakthrough drugs. We may need to make those scheduled around the clock if the patient really is having difficulty despite being on an appropriate prophylactic regimen. Okay, so we're just going to wrap up with a case. So this is a case of AB, who is a 24-year-old female with newly diagnosed right thigh osteosarcoma, who has metastases to the lung. For past medical history, she has a generalized anxiety disorder as well as seasonal allergies, and her medications are listed there. She's on escitalopram, fluticasone nasal spray. And her plan is to initiate chemotherapy with doxorubicin and cisplatin. So cisplatin, she's getting 60 mg per meter squared IV every 24 hours for 2 doses, and doxorubicin 75 mg per meter squared as a continuous IV infusion over 48 hours. So can you guys tell me what some of this patient's risk factors are for nausea and vomiting?
Anxiety disorder.
Ed? So she has anxiety disorder. What else can you think of?
Her age.
Yep, she's young. She's also female, so both of those would put her in a higher risk category. I would say also the chemotherapy agents that she is getting would also be a risk factor. So how would you define her emetogenic category for her regimen?
High.
High.
Good. And what makes you say that?
Both the agents are high risk.
Yeah, exactly. Now, sometimes with anthracyclines like doxorubicin, if they are administered as a continuous infusion, generally you are going to see a little bit less nausea and vomiting than you will see if it's given as a bolus kind of administration. But certainly just the fact that her regimen includes cisplatin automatically puts her into a high-risk category, so we need to make sure that we treat her as such. And then obviously she also has her, her individual risk factors also. So she will be treated with basically the full antiemetic regimen. So what antiemetic regimen would you recommend for her? What drugs would you include?
Aloxi, dexamethasone, and Amend.
So, okay, so palonosetron, Amend, and dexamethasone? Okay,
Yes.
good. So that's definitely an option. Again, depending on your institution. Now, we do not have palonosetron on the formulary here at Hopkins. So here at Hopkins, we would use either ondansetron or granisetron as our primary 5-HT3 antagonist. But certainly you want to make sure that this patient will be getting the NK1 receptor antagonist, the 5-HT3 antagonist, and dexamethasone. Now, based on some of the recent papers that have come out, especially if you were at an institution where they were using the olanzapine, like you could consider substituting the NK1 receptor antagonist with olanzapine, and that would be appropriate as well. Okay, and can you name some of the side effects that you would counsel the patient on in regards to our 5-HT3 antagonist?
Constipation.
Headache.
It could actually, would it if interact with her escitalopram?
I mean, potentially, yeah, that's a good question. I mean, you would need to think about serotonin syndrome. Now, I will tell you that it is not uncommon for our patients with cancer to be on, you know, a drug for depression or anxiety, and then they're also receiving their antiemetic. So I think it's kind of something more to be aware of. And certainly if you have a patient who is on a number of drugs that affect serotonin, then you definitely want to have a more heightened awareness. But I would probably just want to monitor the patient to make sure that there's no issues there. I wouldn't necessarily not give her the 5-HT3 antagonist because of it.
Okay.
So good. Side effects: headache, constipation. You know, some of the other things that we're going to watch for are can have some mild effect on the LFTs. So we would want to watch for that. QTC prolongation. Now that's something that I think is difficult to counsel a patient on because a patient isn't going to necessarily know that their QTC is prolonged, but that's something for us to know as healthcare providers so that we can make sure we're doing the appropriate monitoring with EKGs if needed. Particularly if a patient, we don't normally just do EKGs if a patient's on a single serotonin antagonist, but certainly if a patient is on multiple QTC prolonging drugs, then we would want to think about that. Okay, good. So now it's day 8 of cycle 1, and the patient is admitted to the hospital with intractable nausea and vomiting. She reports 6 to 8 episodes of vomiting daily since day 4, and she admits to not taking her breakthrough agents as instructed. She waits until she's really feeling pretty awful before she starts them. So what are some of our drug options that you could recommend in this setting?
Metoclopramide.
Mm-hmm. Yep, you could definitely
Or,
consider metoclopramide.
yep, or the olanzapine.
Mm-hmm. Yep, I agree. I mean, you could definitely think about, first of all, thinking about what agent she has available for breakthrough nausea and vomiting at home. The first thing I would think about is, was the agent not effective because she was waiting too long to take it? Because sometimes, in my experience, I've seen patients that, they won't take it kind of um, at the appropriate time, and then they will say the drug doesn't work. But sometimes actually when you can get them to use it at the appropriate time, you can see that there actually is some efficacy there. Because I find that once patients say that they don't like an agent and they stop taking it, it's hard to go back to that agent. So you could consider looking at what she was getting, talk to the patient, find out exactly how she was taking it, and see if it's worthwhile to try to utilize what she already had for breakthrough. As you guys mentioned, you can definitely use some of your other like dopamine receptor antagonists, so like Reglan, Haldol. Um, Certainly, you could use olanzapine um, if if you think that the patient has kind of tried some of our more classic agents and is really falling into that refractory nausea and vomiting setting. And then we have some of our other drugs like our cannabinoids, our antihistamines, um, our benzodiazepines if it seems that she's having, like with her anxiety component, that that's triggering more of an anticipatory effect. So definitely a lot of different options, but I would say you kind of want to be selective in how you use the drugs. It can be very challenging if you throw a ton of drugs at the patient all at one time. Um, and then if it works, trying to figure out like what the drug was that worked, because then you're kind of in some ways obligating the patient to go on that many drugs with every future cycle. So just some things to keep in mind. Okay, so how would you counsel this patient to try to avoid this from happening with her future cycles?
Make sure she takes her medication as soon as she feels nauseous.
Mm-hmm. Good. So we like to tell patients this is really not a time to be stoic. Like we want you to take your medications as soon as you start to experience something because it's much easier if you catch it earlier than trying to treat it when you're actively vomiting. And at that point, it can be very difficult to keep medications down. So having the patient take um, their breakthrough agents at the first sign of nausea. Um, it may be possible that, again, some of the agents that we would normally use on a more PRN basis for her future cycle, we might need to make those around the clock as well. So let's say prochlorperazine, that, maybe we need to add that as a standing Q6-hour dose with her next cycle of chemo to try to give her that extra coverage during the period in which she's most likely to have problems. Um, Certainly, you can try to think about other dosage or other options that will cover different neurotransmitters that you may not already be covering, and also thinking through other dosage forms. Now, what you do want to be careful of and think through in our patients with cancer is, so you can certainly use oral or IV or transdermal. With rectal administration of antiemetics, it kind of depends on your patient population. So since I work with more of the heme malignancy population, we tend not to use anything rectally for antiemetics or any other drugs for that matter, because our patients tend to be profoundly neutropenic for a prolonged period of time. And so if you do any rectal administration of medications, you potentially run the risk of introducing like small tears into the rectum and increasing the risk of infection. So we avoid rectal administration in our heme malignancy patients that are neutropenic. But like in a solid tumor patient, for example, where, during periods where they're not neutropenic, you could potentially consider rectal administration if a patient is really having a difficult time keeping their medications down. So you want to think through some of those other nuances with that particular patient's disease state and treatment also. And then certainly, just trying to do some education on lifestyle changes. So It's amazing what you will see patients try to eat sometimes, even after having like really severe nausea. Like I had a BMT patient a couple months ago where he had horrible nausea and vomiting for multiple days, and then he finally felt better, and his first meal that he chose was a breakfast burrito. That did not sit very well and triggered more nausea for him. So you kind of want to do some education for patients on avoiding really spicy foods. Um, you know, I think people are obviously used to sitting down for large meals several times a day. So telling them that during periods of nausea and vomiting, they might need to think about having smaller, more frequent meals during the day. Um, those sorts of things, taking small sips rather than like gulping beverages down, all of that can also kind of help control nausea and vomiting as well. Okay, so just to wrap up, so in choosing our antiemetic regimen, we want to choose it based on our chemotherapy drug with the highest emetic risk in the regimen, patient's previous experience with certain antiemetics or patient-specific risk factors. And we also want to make sure that we protect patients throughout the period of risk, so at least 3 days for a high emetogenic risk regimen and at least 2 days for a moderate emetogenic risk. But for many regimens, you will even see it extended a little bit beyond that. And then certainly prevention is key because it definitely is easier to try to prevent than it is to try to treat once you have a patient who is actively vomiting. So there's a list of references that I think are helpful for you guys. And do you have any questions at this point that I could answer for you?
No, I don't have any questions at this time.
Okay, very good. Well, thank you guys for attending. If you do think of anything after the fact, you can always get my email address and contact information from Antoinette, and I would be happy to give you any additional information that you need.
Okay, thank you very much.
You're very welcome.
Thank you.
Thank you. Antoinette,
Bye.
is there anything else I need to do?
No, thank you so much. Our next presentation will be in February. Trainees, look out for this recording in the e-learning system. Thank you very much.
Thank you.
Okay, thank you all. Bye-bye.
Bye-bye.